Thank you, Judy. Thank you for joining our Learning Lab today. I'm Megan Shinkarik, National Sales Manager, and I have been with Limbs and Things for 5 years, but I've been working with clients in the simulation market for up to 10 years. Success through collaboration is something that Limbs and Things prides themselves on. It's been an important part of our company and has success within the simulation market. Today, we are collaborating with Dr. Shad Deering in San Antonio with a long list of research within the simulation and OBGYN market. Dr. Deering is a board-certified maternal fetal medicine physician who joined the Baylor College of Medicine and Christus Healthcare System as the Director of Medical Simulation. He uses his skills within the simulation market throughout the entire Christus system to ensure a streamlined approach to his program. Previously, he served for almost 30 years in the U.S. Army, in which he set up simulation centers at all 10 Army training hospitals, which are accredited by the SSH. His last positions include the professor and chair of the Department of OBGYN at the Uniformed Services University at Health Sciences. He is a national leader in medical simulation training and patient safety, focusing on practical applications. His efforts and organizations he has worked with have trained more than 500,000 medical professionals during his career thus far. Dr. Deering has also served as the chair of the ACOG's Simulation Working Group, where he designed and implemented the Emergency and Clinical Obstetrics course, which he will speak more on. Most recently, Dr. Deering was tasked with leading the hospital COVID-19 response, and he has served as the medical incident commander throughout the pandemic, working to keep the staff and patients safe and ready to continue the care mission. While balancing all of these tasks, skills, and recognitions, we are excited to have him working with Limbs and Things today to bring his direct knowledge to you. Also assisting the session, Dr. Robin Wooten is a nurse with 35 years experience in perinatal and healthcare simulation settings. Her bedside experience includes labor and delivery, postpartum, NICU, surgery, and the recovery room settings. Dr. Wooten was the inaugural director of the healthcare simulation program at the University of Missouri of Medicine in 2006. While building the simulation program, she also oversaw the construction of the program's first clinical simulation center in Columbia, Missouri. Robin was elected to the board of directors of the International Society for Simulation and Healthcare in 2007 and was recruited after a year to become the executive director of the society. During her tenure as CEO, Dr. Wooten established the first staff of the society, initiated the accreditation and certification programs, and had full oversight of the annual International Meeting on Simulation of Healthcare and the Society's journal, Simulation in Healthcare. In her role, she has also published articles and traveled around the world as a spokesperson for the society. Robin joined the Limbs and Things team as the Global Chief Learning Officer in 2014. She's based in Bradenton, Florida with her husband, Paul, but frequently goes back to Missouri to visit family and her grandchildren. Robin will be covering the chat function on today's session to answer any questions about the objectives or products. So please utilize this if you have any, and there will also be time at the end for some Q&A. The products included in today's lab are a new clean bleed mat and our Prompt Flex Advanced system, which offers options to purchase as a single hemorrhage trainer or part of our larger systems. The Prompt Birthing Simulator has been a long-standing flagship product for Limbs and Things that was redesigned in 2016 to include a modular system to achieve additional modules such as C-section, compression suture, postpartum hemorrhage, and cervical dilation and effacement. It is used in simulation trainers and hospitals across the globe, and the Prompt is the ideal trainer to achieve trainings in all modalities. It allows options to use the simulator as a standalone trainer or a hybrid trainer with a standardized patient. Our new clean bleed mat has been designed to support all simulation scenarios with any brand of trainer where external blood or fluid loss is key indicator. This easy to set up and mess-free product has the ability to create the impression of hemorrhages, such as postpartum, post-operative, or gunshot trauma, through a controlled flow into a sealed mat. The flow into the mat is adjustable and can be easily managed, creating a realistic scenario where the trainee or clinician is able to identify fluid output and respond accordingly. Versatile and efficient, the clean bleed mat can be used under or beside simulated patients, full body mannequins, or task trainers in both indoor and outdoor settings. This video is a little quiet, so if you want to turn your volumes up on your computer, it would be helpful.
Designed to support many training scenarios in an outdoor setting or classroom environment. Change the impact of intervention on the patient with controllable blood flow for realistic, true-to-life emergency practice. Easy to use, no mess. With reusable mats, the innovative design creates a closer-to-life simulation. The Clean Bleed mat from Limbs and Things, enabling simulation training for over 30 years.
Before passing along to Shad, I just want to quickly go over our learning objectives for today. The biggest point is that we're going to go through the racial disparities in obstetrics and how to teach diversity in your program, understanding the Joint Commission requirements and how to include ongoing education for OB teams, review of concepts of teamwork and communication for cases complicated by shoulder dystocia, postpartum hemorrhage, cord prolapse, and vaginal breech delivery using our Prompt Flex birthing trainer, and as well as summarizing sources for teaching and practicing safe obstetrical care. As a reminder, this session is being recorded and will be available post-show to share or rewatch. And again, as mentioned by Judy, please visit us in our hall after the session to go over any products that you may have specific questions on. Without further ado, I'll pass it along to Dr. Deering.
Thank you. All right, I'm going to push some buttons and make sure that we're in frame here so people can see. All right, and then I'm going to look at Robin. And Robin, I'm going to give you, so give me a thumbs up if you can hear me okay. We're good. Okay, we got the thumbs up. We got the thumbs high. We're going to go back to the sharing screen. So I'm going to hit F5. There we go. I'm going to flip through this. So we're going to get back to the thing. All right. Here we go. All right. So now we're gonna switch off, take a mask on and off here so that I can talk here. So first of all, thanks so much for the invitation. Really excited to be here and to get to talk about doing simulation training, both in situ for obstetric emergencies. I do love doing this. This is always fun to talk about, and this is really one of those things. The only thing I will say is in my intro, when they said I was in the military for over 30 years, it makes me sound really old, which is all good. So I think this last year has just been one of those years. I will say I personally love Baby Yoda memes. I think that, you know, it's one of those things that when you see them, there's just no way to be in a bad mood. So I saw this, like, I've almost completed my 90-day trial of 2020. How do I cancel? I will tell you that the first month of 2021 has been challenging, but I do feel like the light's coming and we're moving through it. But it's been really challenging. It's been a really different year for doing training in obstetrics and all simulation. I think we've had to switch a lot of focus to virtual as opposed to how many people we can get in person. And I'm going to talk a little bit about that because that directly relates to obstetric training. Financial disclosures. I have no financial disclosures related to the contents of this presentation. And then the learning objectives. You know, I want to say that the number one that we put up there about racial disparity in obstetrics and teaching diversity, I think it's probably one of the most important ones. And it's also one of the ones that we do not have a lot of data with regards to simulation training. There are some corollaries with regards to gender differences in terms of maternal cardiac arrest that I'll talk about. But it's really, you know, as we look into it and you look for the literature, I'm going to talk a little bit about a study that we're going to be doing here where we're going to be looking at that. But it's one of those things where I think it's a field where we are all starting to dive into and really try to get to the bottom of it so that we can improve outcomes for our patients. We're going to talk about the new JCO requirements for ongoing OB education with regards to emergencies, teams, and doing in situ training. And then what I'm going to spend some time doing is I'm going to talk about what are some of the national programs that are out there, what does it take to run them, how we're actually moving towards some of the virtual options. And then we're going to talk about like, here, what are the resources that are out there? We don't want everyone to have to reinvent the wheel. We'd love for you to be able to take this stuff and then go spend your energy training and improving outcomes for patients. All right, so it's an interesting question. This actually came up in the paper. It said, if Americans love moms, why do we let them die? And it turns out that an American woman is 5 times more likely to die than if you're in the UK during pregnancy and childbirth. And I actually had a patient ask me this question. They said, why is it so different here? I mean, we're the United States, we're a developed country, like what's the difference? And there's not a simple answer, but there is a simple focus. The simple focus is that we've got to address it, we've got to turn our attention to it. And one of the big ways to do that is through simulation training. When you look at these numbers, and it says 38% of maternal deaths were pregnancy related and up to 80% were potentially avoidable. Like that's just a huge opportunity. And so that's really where we spend a lot of our time and efforts. If you look at the most common causes, hemorrhage, infection, and cardiac, and then we also have hypertension, and preeclampsia is just becoming more and more common. So when I talk about disparities and we talk about differences in care, let's start with gender. So this is some really interesting data that came out about CPR and women. And it turns out that if a woman collapses on the street, having a cardiac arrest and a myocardial infarction, they're significantly less likely to get CPR than a male. And the question is why? So they actually did this study where they basically, talked with people about simulation. They talked to people about, doing CPR, and they looked at data, and they came up with several things that people said. They said, misperceptions about women in acute distress. In other words, they didn't think that it would be a heart attack. That just wasn't in their mind. That wasn't the first thing they would think. They were concerned about hurting the person in terms of where do they put, and also where do they put their hands. So even just little things like that can affect the delivery of care. So if you take this corollary and you take it like, okay, well, if we have this issue, just doing CPR, which I don't think anybody has any issues with CPR, and then you move that towards racial disparities. There's a huge gap. So this is a slide I put up there, racial and ethnic disparities in New York, severe maternal morbidity. So if you look at that, from a Black female, it's 2.3 times higher. So we know that there are differences. We're still trying to figure out why. Is it access? Is it care? Is it once you're in there, are there these inherent biases and these microaggressions that we talk about? Are there things like, what are the things that are causing those barriers? I've been reading several articles. I actually find this one really interesting. So if you look on the right here, it says racial gaps seen in response to out of hospital cardiac arrest. So they talk about, what are the issues with that? But I just want you to take a look at that picture real quick. So take a look at the picture. And this is where this is hard because it's virtual and I can't ask questions and I can't get feedback and I can't see what you're doing. And I can't see the facial expressions. But I want you to look at that. I just want you to take about 5 seconds and I want you to see what's interesting about that picture with regard to the title. So I'm going to just give you 5 seconds. Okay, so if you notice that you have a white mannequin, and then you have someone of darker skin who's actually doing the CPR. So CPR mannequins and trainers, and there was an interesting article by a medical student about that who said, I went to do CPR training, and I went to this training, and every mannequin I found didn't look like me. It's one of those things where if we talk about barriers, if we talk about barriers to training, if we talk about barriers to response, it's one of those things that falls into the common sense, but I really want to see data. But I want to address it before we have the data because I don't think it's worth waiting on. So again, what you're seeing now is you're seeing a lot of companies, and today we actually have the dark skin tone for the limbs and things. You're seeing a lot of companies that are starting to move towards this in terms of offering you multiple options. As we started in my new role as the Associate Dean here for Baylor, we started a diversity and inclusion committee. And one of my first questions, they said, well, what are you doing in the simulation center? I said, that's a great question. Let me go look. So we went through all of our simulators and mannequins. And in all the ones we had one that wasn't white. And so we looked at our population. And so we're in the process of actually putting things together because what we want is we want our training experience to look like the patients that we take care of because we have got to figure out how to decrease any of those barriers. Because there's not as much data out there, at least not in simulation, as I think that there should be. We actually just did receive a grant. So we're actually going to be running a study in the next several months where we are going to be doing pediatric resuscitation. And we're actually picking two scenarios. One's trauma, one's a sepsis. And we're going to be doing it with standardized patients and mannequins of different skin colors. And then we're going to look at the care. We're going to look at the differential diagnoses to see if they're different. And then we're going to have the participants take an inherent bias test. And we're going to see if we can correlate those. So again, this is one of those areas that we feel really strongly is really important, and we don't have as much information about it from the training side as we think that there should be. So we're working really hard to start to answer some of those questions. All right, I'm going to move on to talk about Joint Commission requirements. So the Joint Commission originally put requirements in place that were supposed to start in August of 2020. A couple things happened in 2020, including an international worldwide pandemic. So this actually did get pushed off to the 1st of January. However, it is now the 3rd of February, so these have been in place for a month. So the Joint Commission has come out and said that there are requirements to address maternal morbidity and mortality, and some of those training that needs to happen is we need to be able to do courses. And so if you read here, it basically says, let's see, role-specific education to all staff and providers who treat pregnant and postpartum patients about hemorrhage procedure at a minimum at orientation, whenever changes or processes occurred, or every 2 years. So that's the language. These are always a bit broad, but again, this is out there for so we have got to be training people. This just says hemorrhage. However, I think we all know that it needs to be broader than that. So there's hypertension, there's sepsis, there's COVID. So there's a lot of different things. But again, at least it starts with hemorrhage. And then if you go to the next requirement, which is number 5, it says conduct drills at least annually to determine systems issues as part of ongoing quality improvement efforts. It should be multidisciplinary in an organization and give people the opportunity to practice skills and identify systems issues. So my background is not in education. My wife's is. She has a master's degree in education. And so a lot of times I'll come up with stuff and she'll be like, yeah, we learned that on day 1 in our first class. But just in general, I don't think it makes a lot of sense to practice something 1 time a year in your hospital. I don't think you're going to get much out of it. I don't think that's going to create a culture of constant change and improvement. So this is a great start. The language says every year. If people want to meet the minimum standard, that's fine. That's really not adequate. I don't think anyone would argue that. But what I put over here to the right side here is that there are some national programs that are out there that can help address these things. So for the first one, in terms of role-specific education, at least every 2 years, there's emergencies in clinical obstetrics, so the ECO course. And then on the in situ drills, there's practicing for patients. Both of these are obstetric focused, so I want to spend a little bit of time on them. Now, when we look for other places and to see what they're doing, so the Defense Health Agency, which is basically the military's medical, they require monthly drills on every unit, and you can take the ECO or the ALSO course. So that's what fits your that's what fits your basically core training. Think of it like basic life support, except it's focused on obstetrics. They require every person who touches an obstetric patient, from the nurse to the doctor, everyone has to go through one of those courses every 2 years. They've actually bought simulation packages for the drills and put it at all the institutions. They have a high fidelity. They have a high fidelity, and they also have a prompt. So you can run all of these on any of them. And again, that is an ongoing thing where they require it. So let me talk a little bit about the ECO course. So this is a simulation-based course taught by ACOG. It actually started back in 2010. It just wasn't called this. And after doing this for a few years, we were running this at the annual clinical meeting, and we had lots of people say, wow, we'd really love to do this at our institution, or how do you export this? And we realized we really needed to take it, we needed to formalize it so people could do that. It's focused on multidisciplinary teams. So we have docs, we have nurses, we have midwives. We really have anyone that wants to come through can come through. We worked on formalizing it and formatting it so that in 2015, we were able to offer it as a formal course. It addresses 4 obstetric emergencies and another key topic. So shoulder dystocia, breech vaginal delivery, cord prolapse, postpartum hemorrhage, and then there's a teamwork and communication related to obstetric emergencies part that comes with it. You can teach it in a sim center, or you can teach on labor and delivery. You can do either one. It's approved for CME as well as ABOG maintenance of certification credit. So you may be asking like, I haven't heard of this. Well, that's fair. Part of starting a new course and getting it out there is really getting your instructors trained. The good news is that over the past 5 years, we've gotten to where we have over almost 350 instructors trained now. We've trained close to 2,000 providers. So it's gone from the annual meeting to where we have organizations that are putting it into their core curriculum. They're teaching all of their attendings. We've run additional courses up in the Northeast. So again, this is something, in fact, we just trained Montana virtually on how to run this, and I'll talk a little bit about that. In terms of courses by year, so we've trained 255 courses to date, 109 sites. So again, it's continuing even with the pandemic in 2020. It still didn't drop off nearly as much as we thought it was going to. So we're really excited for 2021, probably like everybody else is. So what has changed is that the eco course was you would come sit in person, we would do a lecture, we'd go over all the topics, and then we would talk about teamwork as well. And then you would go to stations and you would practice. So that was the model. That is shifting. And as of this month, what's coming out is it now goes to an online version and then hands-on stations. So the difference now is we have very standardized lectures. They've all been recorded. We have examples of the simulations being run. You go online, you do all of those things, and then you show up for your hands-on stations. Once you've gone through the 4 hands-on stations, you get a certificate, you get 6 CME credits, and then there's MOC Part 4 credit that's automatically credited if you're a licensed obstetrician. And with that, I want to take a minute because I do want to talk a little bit about the different stations. So the stations look a little bit different. When you talk about shoulder dystocia and breech specifically, it's more focused on skills. So even though we will walk through a clinical checklist that we have for each one of these, we spend a lot of time going over skills and practicing and talking about them, as opposed to cord prolapse and postpartum hemorrhage, where that's much more of a team environment. And so even though we will talk about the checklist and we'll go through them, we will run a full scenario with those. So we'll have physicians, nurses, midwives, whoever's there. We will assign roles. We'll talk about hemorrhage. We'll go over the content from the lecture, and then we will just run scenarios, and then we'll go through and debrief them. So I'm going to click escape here. I'm going to put us back. And Robin, can you tell me, do we have a full screen now for the for us? No? Okay, I'm going to hit stop share. There we go. All right, I'm going to hit stop share, and then we're going to talk a little bit about how some of the stations run. So I'm going to pull this over.
Shad, for just 1 second, little housekeeping thing. If you click on the 3 dots in the top of Shad's box, click on that and click pin. His video will come full screen for you.
How's that? Better?
Yes.
All right. Okay. I'm going to move this down a little bit. We're going to talk a little bit. So, and then I'm going to try and stay out of the frame. So we're going to turn this around. So you want to do the shoulder?
Yeah.
Okay.
Are we okay here or?
Yeah, I think you're good there. All right. So when we're talking about shoulder dystocia, when we're training this course, what we'll do is we'll go over all the maneuvers. I'm gonna grab some gloves. We'll go over the maneuvers. We will talk about risk factors, and then we pull out the clinical checklist. When we're first teaching, what we like to do is we like to explain to them as they walk through exactly what the physiology of it is, where the shoulder gets stuck, how the baby comes out, and then the different things that they need to do to fix it. One of the nice things is that, and this is for the entire eco courses, you can run it with, you can use a very high fidelity simulator, or you can use, say, even just a prompt flex. I mean, this works perfectly fine. One of the nice things about this is, and doing the shoulder dystocia, it's really nice if you can have the force feedback. And by force feedback, I mean, you can see how hard you're actually pulling. So I'm gonna come around this way. So one of the things when we're first starting, so we talk about, we have the head kind of, so we'll have the head come out. And when we go through, and we kind of pull it back, it's nice, especially when we're starting, is we like to, a lot of times, actually not have the belly on. And that's so that we can walk people through and show them exactly what things look like on the inside. So when we have the, so we have the belly, so a lot of times we'll take it off so that we can show them what's going on. And so we'll say, okay, baby's there. You're basically gonna not get anything. You're going to say, I have a shoulder dystocia. We talk about doing McRoberts, suprapubic. But as we're teaching people exactly how hard to pull, one of the best things, and we really enjoy it, is like showing people how hard they pull. And so what you'll see here is we have this set up. So as people kind of pull down, they can see exactly when they're starting to get a little bit too high. And one of the things that I really do try and teach people is don't drop your hips. So if you want to pull too hard, if all you're doing is pulling here, it's a little difficult. But as soon as I drop my hips, I can very easily pull too hard. So this is a really nice force feedback because nobody has their hands calibrated to start with. And so this is a great way to show them exactly, okay, here's how hard you are pulling. Here's essentially where you want to be. And again, it's really interesting to see how hard people pull and what they think they're pulling. So after we show them that, we'll go through and we'll talk about different maneuvers. Probably the thing that people are the least comfortable with because they just haven't had a lot of experience is posterior arm delivery. And so we will teach them. We always, I think it was our midwife in the UK who talks about not leaving your hitchhiker thumb out, and she talks about the Pringle maneuver. And so we teach people how to get their hand all the way in and exactly how far up they have to get it. But again, it's one of those things when people are doing it, they're just, if they haven't done it before, I think this is one of the most valuable things that we can teach people. And again, physicians, nurses, everybody, because you never know, and since precipitous delivery is a risk factor for it, you never know when it's going to happen. So being able to go through and teach posterior arm, and the other thing you can do is you can show them in the different positions where the arm is. You can say if it's here, so in other words, I'm going to bring it here. If it's flexed, you can show them how to get it out. You can let them see and feel what it is like when it's extended. And then you can show them what it feels like when it's actually stuck behind. So this is one of those things where we will go through, we will visually show them the baby, show them the different positions, put the baby in, and then let them do it with their dominant hand. And then we'll actually have them do it with their non-dominant hand as well. So the difference in the shoulder dystocia and the breeches, we spend a fair amount of time actually going over technique. And that's because the technique is really challenging. Okay, I'm looking at describe the calibration process a bit more. We do calibration, but have a different process. Do you want to describe how to calibrate the baby?
Yeah, so prior to linking it up, it's a Bluetooth baby, so it will work with any Bluetooth device. I typically lay the baby flat and make sure that they are zeroed out prior to using. And I suggest going into the the meter mode each time to calibrate that and make sure that that's set to 0. And then once that's all reset, you should be good to go. And you can run within drill mode or within meter mode. The drill mode will give a little bit more. Yeah, the drill mode will give a little bit more detail as far as time across the intervention, where the meter mode is just going to show a static determination of the force being applied.
Oh, there we go. All right. See, I'm not that tall, so I have to put things higher. So anyway, so after and this is the fun part of talking about this because a lot of times I'm giving these talks, I'm talking to people that I'm having to, explain why this is important, whatever. You guys are easy in that sense. Like you're here on purpose. So technical questions, stuff like that, fantastic. Please keep them coming. So for the drills themselves, so again, shoulder and breech, lots of time working on technique. And that's just because not a lot of people do breeches. I don't think almost any of us do them on purpose, but they do happen. I used to joke that actually the best person we had to deliver breeches at my last hospital was one of our labor and delivery nurses named Lee. And it's just because they would always be precipitous. I think he'd done 3. So we used to joke whenever we had one for a resident, we'd call the nurse and have him come in and teach us. But they do happen. And there are things that you can do to hurt a baby if you don't do it correctly. And additionally, the maneuvers that you do for a vaginal breech delivery are exactly the same maneuvers you do at the time of a C-section. And I say everyone does C-sections for breech. So you still have to understand how to bring the baby out, how to protect the head, how to not stress the brachial plexus, all of those things. So again, we think breech is still very, very important. Now, the difference is, I'll come over here a little bit. When we're running postpartum hemorrhage, or we're running umbilical cord prolapse, then it's set up a little bit differently. So what we'll do is, like, let's say for cord prolapse, we'll go ahead and we'll put you go ahead and plug it in. So if we're doing cord prolapse, the way we'll run that scenario, we'll bring it up. Pull that cord down just a little bit. We'll bring the cord down and grab the belly. Put it on top. There you go.
Yeah.
So we'll get things set up, and then this is the really nice thing about using a simulator like this, in the sense that one of the pieces that we find all the time in simulation, you probably found this yourself, is people have a hard time remembering to communicate, or having a hard time remembering to talk to the patient and do stuff. So whenever we do a hemorrhage, or we do a cord prolapse, especially with this model, we have somebody who's sitting on the bed, who has a gown on, who is the patient. And if they don't talk to the patient, then we will say things. So we'll be like, oh my gosh, what's going on? What do you mean I have to go do a C-section? Is my baby okay? So having that interaction, we feel, really makes a huge difference, as opposed to just a very static, I'm walking through a drill and doing that. And that is one of the great things about being able to do it this way. Now, we set it up similarly for the postpartum hemorrhage. One of the interesting things, and we were talking about this last week, in terms of the clean bleed map, when we do the postpartum hemorrhage, one of the unique things about this is now it gives you the ability to do the delivery if you want to, and then follow it with a hemorrhage. A lot of the designs before have been, well, and even this one, like there's a uterus. Do you have the hemorrhage uterus? So one of the things that does change is, so there's a hemorrhage uterus, which is really nice because you can feel and you can see if it's boggy or if it's firm. So you can run the postpartum hemorrhage, and the scenario can be that the baby's been born and then you have the hemorrhage. However, when you have the clean bleed mat, you can actually do the delivery and then make it bleed, which is different, because when this is in place and that's purely what you're doing, you don't have that option to switch them. So that's actually really nice. So I know you saw the video, which was basically like the parking lot and the person. I don't know if she got shot or what happened to her, but anyways, we'll show you real quick just kind of what the clean bleed looks like on here. So I'm going to let you turn that on. I'm going to put it on, and I'm going to see if I can get this camera just a little bit closer. So, and do you want to show them the pump?
Yes. So it's all controlled here. So off.
All right, so there's the pump.
There we go.
And the really interesting, and this is where all the people who have to clean everything up will like you. Because I don't know about you, but I'm always winding up talking to them like, I'm just really sorry. I'm really sorry we made a huge mess.
And I have that cranked up as high, so it is adjustable to have a lower steady flow, or to really have it hemorrhage out.
Mm-hmm. So the other thing that's really interesting about this that we've been playing with is that when you're done with it, so show them how you just reverse it. So when you're actually done with it, you take these off, you reverse it, and then you can actually suck the blood back up. So not only do you wind up not using as much, but it goes back into the tank, and then these sheets can come out, and you just wash them out.
This one wasn't cleaned completely, but you can see that
This one we actually left for days. So, but when you do it right away, it actually comes out, and you just wash it out, and then it can be cleaned, and so you can just continue to use it. So not only do you not make a mess here, which I think is really nice, but it gives you an opportunity to do a actual delivery and then talk about postpartum hemorrhage. So this is the first time. I just saw it a few days ago, but this is something that I think we definitely want to try and use in our course, just because it gives us that option. Okay, so I'm going to flip back a little bit. I'm going to turn this up, and I'm going to go back to our slides. This is always the fun part on the virtual stuff, is figuring out exactly how to keep things interactive while talking to a camera. All right, I'm going to ask for technical help. Do I hit unpin something? Or do I just keep going, Robin?
No, Shad, you just keep going. Everyone can pin and unpin you from this side.
Okay. F5, okay. Can you see my slides, Robin?
Yes.
Aha. All right, I'm going to flip through. I don't want to look at myself again. There we go. Great. Okay. All right. So what does this course look like? So the Emergencies and Clinical Obstetrics course, if you do everything online, then you show up, background, introductions, orientation, about 15 minutes. And then depending on the number of people that are there, stations take about 45 minutes. The instructor to student ratio is 1 to 5. So 1 instructor for every 5 participants. And you can get through this in, it's about a 3.5, 4-hour course when you do the front and the back. But it's great because everybody gets to go through things. Everyone gets to get their hands on the model. And we've really enjoyed teaching us. I will say, so Limbs and Things donated an ecosystem. So again, this course is through the American College in OBGYN. And Limbs and Things did donate an entire system there. There are different ones. I think you're going to talk about those at the end.
Yeah.
Does that sound right? Because you can run the entire course with the prompt models. Again, you can use high fidelity. You can use other ones. You do have to make sure that whatever simulator you have, you can do a shoulder dystocia realistically, and you can do a breech. That really depends more on the baby than the pelvis. Because some of them some of them it's they don't have the joints. It's just harder to do. We've done these in person at ACM, and again, ACOG's really excited to be able to utilize this to expand the training. Now, has the pandemic changed anything that you're doing for simulation? It's changed a lot for us. Just so you know, that picture is me in a hazmat suit. That was for the Ebola scare, actually, we had a few years ago. And one of the military units whose job was chemical, nuclear, biological response, they had been deactivated, and they showed up at our sim center with a whole bunch of equipment and said, does anybody want this? And of course, I couldn't say no. I will give you one word of warning. Don't zip that thing up all the way unless you have the fan, because you will suffocate. And it's kind of hard to get unzipped. So just a word of warning. But I did practice doing some deliveries in it. It's really hard. You can barely hear. I think as we've all gone through COVID, it's been a generational experience in terms of how do we provide safe care while keeping all of the providers, our patients, and their babies safe. I've seen some data that's come out in terms of harm indexes, and it's as we focus so much on COVID and all the things that are required for that, some of those harm indexes have started to go up. And so what we're figuring out now is not only how to live with it, but how to still provide safe care during it. A lot of sim centers during the pandemic shut down. A lot of them decreased their in-person offerings, trying to do this with social distancing, having a limited number of people in the room. All those are very difficult. So one of the things that we've worked on doing is we've worked on doing some of these things virtually now. So one thing we have created is we've created a virtual eco instructor course. So the way the eco course runs and the way obstetric simulation runs in general, you can't run a team-based scenario with nobody unless you're going to go to a completely virtual platform. And I know that there's some work on doing some things like that. But in terms of if you're going to run it, if you're going to run a course, there are parts that just have to be hands-on and in person. So what we've tried to do is we've tried to take away the barrier and train more instructors so they can do that locally with fewer people and paying attention to the social distancing rules. We've already run a pilot version of this. We did in September. We actually did it again 2 weeks ago. We've trained people as far away. We're in Texas. We've trained people Louisiana, Montana, Arizona, and I think Maryland. So what we've done is we have created, if you've gone through the eco course, and we basically have you go to your sim center, you show up there, you have to have some kind of simulator. You need at least 3 people. You need a webcam, the ability for real-time video, and then you go through the online lectures, and then we teach the instructors. We have them walk through, so we demonstrate the simulations, and we go through, here's what this looks like at our institution, here's how you teach the course. Then we have them basically demonstrate that they're teaching the different stations. And after that, then they're instructors. So that's one of the ways that we're trying to push this out to other places. We have not figured out how to do a virtual eco course, but we have figured out how to train instructors. We're hopeful that what this will do, and again, there always has to be something good come out of the pandemic. So I think we have basically discovered a way that we can increase our training pool and we can offer this to more people. This is just a screenshot of one of the trainings we were doing for Montana. And again, what you'll see here is, this is actually us teaching a breech fastener delivery. After we had done it, we had them go through it, and we were able to talk through it, debrief, explain, different things to teach and how to do it. again, it was really good, and the feedback we got was great. All right, so I'm going to take a minute. I'm going to change gears a little bit. So the ECO course it's a course. Think of it like basic life support. It's an obstetric emergencies course, and it's focused on those 4 things in teamwork. It's meant to be taught in a sim center. You can teach on labor and delivery, but again, it's meant to teach that course. However, with the Joint Commission requirements, remember there's 2 parts. One is you have to have ongoing education. And then the second is you need to have the ability for people to run drills at their institution. So what's the challenge with that? There's a ton. What simulator do I buy? What do I do with the scenarios? How do I organize this with nurses, docs, anesthesia, the emergency department, blood bank, lab? There's so many things. And so people just keep reinventing the wheel. And it's a very typical Joint Commission thing where they say, here's the requirement. And then you're like, how do I do that? And there's no answer. It's just, this is the requirement, which you should be doing. So that is where this program is coming. This is purposely designed to let any hospital of any size run in situ drills on their labor and delivery, because you don't get to a lot of the systems and facilities issues if you're in a sim lab. I mean, it's just not realistic. This isn't where you work every day. This is not where you're going to have to deal with those issues. So it is practicing for patients. So it's built by the ACOG Simulation Working Group. We work with the Council for Patient Safety and Women's Healthcare. It is an entire program with an amazing amount of resources. So you don't have to reinvent the wheel, and you can take the AIM safety bundles and you can put them into practice at your institution. The first one that came out is postpartum hemorrhage. Hypertensive emergencies will be out by April or May of this year. I'm just going to watch check on time. So I'm going to tell you a little bit about what we did in Texas. So we have the Texas AIM initiative, 219 hospitals, 98% of them signed up to be part of this. And so what we did is we decided that in terms of helping them with postpartum hemorrhage, we want to talk about the bundles, but we want to help them implement them and actually do them at their institutions. So we created an implementation course for this. Maternal morbidity and mortality in Texas, not great. This is a top 10 list you do not want to be on. But we patterned everything for this program off of the AIM patient safety bundle, which goes through readiness, recognition, prevention, response, and reporting systems. So we have 5 different cohorts. And again, we created this manual, everything, and we said, this is a national program, but we're implementing it in Texas at this time. So here's what we did. We went to 5 different places. We had over 120 hospitals come. We trained over 300 providers. We started in Lubbock. Then we went to Dallas. Brooke Thompson and I, who's on the ACOG Sim Committee, we did stop at Arby's because it was a long drive. And so I had to put Arby's in there. Did 2 days of training in Dallas, went to San Antonio, did another day, and then went to Houston. This was all about a week before everything in the world shut down with the pandemic. So this was my last road trip. So here's what the course looked like. We would bring everybody together. We talk about what practicing for patients was and why we need to do this training on labor and delivery, besides the fact that it's a Joint Commission requirement. And then what we did is we broke in, we did simulation sessions, and we gave them, here are the standardized tools. Here's a PowerPoint you can take to your hospital and you can brief your leadership and your staff on why you're going to do this. Here's a scheduling diagram, and you can go through and a checklist for all the things you need to set up. Here's cards to show you, here's the vital signs, here's everything else. It literally is a complete package. And they came and then they practiced it. And then we practiced debriefing with them. And so it basically went from 8 to 3. It was led by an amazing number of faculty volunteers. And again, you can imagine the logistics of this going across the state the size of Texas and all these people. But we had a great time doing it. We did it in hotels. We did it in sim centers. We did it in conference rooms. You can really do this course anywhere. So we actually put together bins so that had everything in them they needed in terms of the equipment. If you're teaching it there, if you're doing it on your labor and delivery, you're going to use your stuff. And then we had a sign that said stop Brooke, because Brooke, who's there on the right, who is fantastic, so passionate, always keeps talking. So we had stop like 5 minutes, we're going to stop. We just wrote Brooke's name on it and put it on there. So I was teasing about that. The majority of people that came were nurses, although we did have a fair number of physicians that came with them. We had a midwife. We had some perinatal educators that came as well. And then we did have a safety coordinator. And overall effectiveness, I mean, overall, we got really good feedback on it in terms of, because it's one thing to put it out there and say, here's how you do it. Everything's there. And there's also example videos. It's another thing to then bring people there and then train them how to do it. So we were really excited about it. And then the pandemic. So what's happened now? So now we're taking this program and we're transitioning so that it's going to be able to do, we can do virtual. In other words, we can actually train hospitals, same way we're doing the ECO virtual instructor course. We now have a virtual instructor course for practicing for patients. We have run several of these. We've trained people in Louisiana, Texas, and then a couple of other states. And so we have a virtual training program for this as well. It's the same thing. We teach them the manual, we give them all of the stuff, we then demonstrate what it looks like, and then we let them run it, and we help them kind of go through the process. So again, we're excited because we're going to need to expand this as well. This is also important because the next thing that's coming out, this is a picture of us doing one of those courses. Again, nice screenshot, lots of masks. So the next thing that we're doing is we're actually taking this, and so we're going from postpartum hemorrhage, now we're adding hypertension. The platform is the same, and teaching people how to run drills in situ, that's not going to change. However, it's going to continue to roll out, and it's going to follow the AIM bundles. So we have postpartum hemorrhage. The next is hypertensive emergencies and eclampsia. The next one will be sepsis. They're going to follow the AIM bundles in form and function so that not only can you fulfill the Joint Commission requirements, but you don't have to reinvent things. And once we've taught people how to run drills and do debriefing, it's very simple to then just give them the scenarios, and they can change them later, but give them the scenarios and go on from there. All right, so that is my last slide. Again, I'm a big believer in Baby Yoda memes. They make me smile, and I think during the pandemic, we all need a little bit of that. I will say that I think Disney owns Star Wars now.
Oh, do they?
And people talk about Disney being the happiest place on earth. That's actually not true. I will tell you from my experience over the last month, the happiest place on earth is the vaccine clinic, because everybody comes in and feels like they can finally do something about it. And so that is actually one of my favorite places to go hang out and talk with people. So I'm going to stop right there. I think that's the end of the slideshow. I'm going to hit escape. I'm going to hit stop share. And then do I need to click pin my video? I'm already there.
Yes. Okay, Shad, a couple of questions have come.
Yes.
When they talked about calibrating and how hard to pull, can you talk just a little bit about 100 newtons of pressure and where that came from?
Oh, that's one of my favorite points. So 100 newtons came actually from a single case where they had a system, not this, but they had a system in place in terms of measuring with the glove, and the provider pulled 99.8 or something like that newtons, and the baby had a transient brachial plexus injury. That's where the initial number came from. There is some in situ data that's been done. I believe the group was up at Hopkins that's looked at, like how hard do you pull to stretch a brachial plexus. But that's kind of where it came from. It's a guideline. It's not a hard and fast rule, but it is something, as we've shown, when we looked at, so we actually did a study where we looked at how hard do people pull. Actually, we did utilize this simulator, and we looked at docs, nurses, and OBGYNs, and we had to say, okay, we're going to do a delivery. We're going to see, what your general force is. The first thing is, this is a normal delivery. How hard do you pull? And we'd have them do that. We said, okay, let's say you have a shoulder dystocia. Show me how hard your first pull is and say, yep, I have a shoulder dystocia. And they did that. We said, okay, you've done your McRobertson suprapubic pressure. Show me what your next maneuver is. And then they would apply some traction. And then we said, okay, here's the deal. It's 5 minutes. Nothing's working. This is the last time you're going to pull before you're going to do the Zavanelli and put the kid back in. So show us how hard you would pull. And then they did it. And then we looked at how hard they pulled. On average, in terms of that, it was I think it was around 68 newtons, wound up being for a shoulder dystocia, that initial pull. So I think that's how that correlates with regards to normal. Interestingly, there were no differences between docs and nurses in terms of how hard people pulled. The difference was actually family medicine to OB. And on that final pull, they tended to pull harder, still not 100, but they tended to pull a little bit harder. And our theory behind that is that if you don't have the option to go to a C-section, you might try to pull harder. We don't know, but it was an interesting study. So that's where 100 comes from. It's a guideline. It's not a bad one, but that's the science and at least the evidence behind it.
Okay. Megan, could you hold up the clean bleed pad just for a second? A couple of points that we want to be sure to make. Can you talk just a little bit about weighing the pad and the use of checks with that, Megan?
Yeah, so Shad and I actually were discussing this as well. So a chuck pad can be used on this. It does fit in there nicely as well, and it might be visually more representative as to what they're used to seeing. However, these pads are a little bit, you're going to get a little bit more life out of these. And then in terms of weighing, the piece comes off. So they would disconnect from the pump and they can just run over and weigh. We would suggest weighing the bag and the pad empty and then re-weighing when done. You can also visually see on the fluid reservoir, let's see if I can get that close enough here.
Okay, I'll come bring it to you.
There is a, I don't know if it's gonna let you see, but there is a earmark there for liters as well. So it's again, not perfect because the tubing is in there, but they are able to get a good representation as to how much that is. Shad and I also talked about potentially having an already used chuck pad nearby or underneath to be able to pull that over to measure the weight of it as well. So you can get creative within the simulation side of it.
We also talked about if you had two of these set up, that the first one you would take over and weigh, and then you'd have the next one that you'd be bleeding. So that would be another way to do it. Because we were discussing exactly that, especially as we go from EBL to QBL, which we really are recommending. You know, how do you do that with this? So we were having fun talking about
Yeah,
that.
and the system does come with two of the clear plastic reservoir bags that do keep it all maintained in there. So it's fairly simple just with the hook system to move it on and off and to have additional pieces ready to go.
Okay, I am asking our group if there's any more questions. We have an impressive and really interesting. Thank you, Dr. Deering and the team. Your efforts could only have a positive impact, and those terrible morbidity rates, well done.
Thank you. I also want to say, so just a couple other things. So I don't know if we have the links in there. So if you go to Safe Healthcare for Every Woman, that's actually and that's the AIM site. So Safe Healthcare for Every Woman, and you look for Practicing for Patients. The entire program is available on there. And again, Practicing for Patients, it's free. All of every resource that comes with it in terms of the videos, the explanations, the simulation tools, the simulation scenarios, the PowerPoints, everything is on there. You can take it, you can just run with it. We are trying to work and to see what we can do in terms of offering more national implementation courses in that, just because people feel more comfortable if they've gone through something like that. But if you're already running simulation, which I'm going to guess a ton of you are, you can just go to the website. Like it's literally all there. And hypertension will be there within the next several months. It will definitely be there by May. I'd love to see it by April. We turned in all of the revisions about 2 weeks ago. The Patient Safety Council Subcommittee met last week and went over it. So I'm waiting to get those back, and then we're going to turn it around. We still have to film the scenarios, but that hopefully will be the last part, and then we'll be able to get that out there. But we're really excited about it.
Thank you. Anyone else? We had a question about will practicing patients' hypertension be ready soon? And I said April or May, and you kind of confirmed that again. I did add a couple of links for you all to look at the configurations of the PPH on the website, and also the different eco courses, which Dr. Deering was very, very integral in the creation of those kits, and to make sure that it's all inclusive for your training.
And Robin, I can explain a little bit of that. So there are different size kits, and it really depends on, it's based on the 1:5 ratio. So you can run so we're going to go back to eco course. People always get confused between the two. So we're going back to eco course. So when you're running that, there's different ways to do it. And so I think that's where like the amount of equipment that you need, it depends. We run it at the annual clinical meeting, and we have 50 to 60 people go through. We have 4 stations set up and multiple simulators at each site. And so again, like we'll have 2 at shoulder dysstocia, 2 at breech, 1 for postpartum hemorrhage, 1 for cord prolapse. And we do that so that we can get that many people through quickly. If you're running a course where you have 5 people, you can do it with 1 simulator, because you're just going to go from one to the next, to the next, to the next. If you have 10 people and you want 2 stations, and then you're just going to switch them, so they'll basically do a station, switch, and then switch back, you can do it with 2. So the packages were really, the reason the packages were designed that way was it depends how many stations you want to run at the same time and how big your course is. Obviously, the more stations you can run at the same time and do the hands-on, the more people you can get through in a shorter amount of time. But that's That's just the purpose for those numbers.
And we put the packages together on the website, and there are built-in discounts on that as well. So because the packages were put together with those stations in mind, there's discounts that are built in, small, intermediate, and the large ecosystems.
Okay, I'm not seeing any more questions. I want to take that chance to just thank you personally, Dr. Darian. You're one of my favorite people, and it's been a
Aw, that's
pleasure
nice of you.
to work with you and to hear all of your good information. Certainly, if you have questions, you can reach out to me, to Megan. You can go straight to our booth. We have people on the booth ready to answer your questions, but this has been a very good pleasure. I wish we were face to face, but virtual actually worked pretty well.
Yeah, we'll do this again next year.
Oh, I'm counting
Hopefully
on
in
that.
person.
Hopefully in person.
Yes. Judy, do you need to have any more closing thoughts?
No, I'm really raspy this morning. Just to thank you as a platinum sponsor to IMSH Delivers. I do encourage all of our attendees to visit you at the Industry Hall. It was a great presentation, and thank you for your support and the information, and definitely for the education.
All right. Okay, everybody, we'll sign off. Thanks very much for your attendance.
Thank you, everybody. Bye-bye.
Bye.
Bye.